To introduce Professor Cattaneo, who has also previously been here in other meetings in Metzovo. Professor Cattaneo has also a huge amount of research, and he's working in cardiovascular medicine department, Bellinzona, Switzerland.
Pardon me?
Is it correct?
What do you say?
In Milano. You're working in Milano.
Milano, yes.
Okay.
Yes.
And his
And
talk
my team
will
is
be
AC Milan.
again on platelet function.
Yes. Thank you. Thank you.
And response to aspirin in patients with essential thrombocythemia. It was a false address which I found in the internet in Switzerland. So
No.
it was a
Don't
bit
worry.
confusing. Okay, Professor Cattaneo.
Okay. So, actually, I'm talking about patients with the essential thrombocythemia. Now, first of all, thank you, Alexandros and John, for your invitation. I'm an old customer of this. I think I was here the first time. So I will try to squeeze in a hopefully 20 minutes presentation three parts. First of all, I will address a brief overview of the literature, and then I will present you some data from original studies in my lab. So, essential thrombocythemia is a pH-negative chronic myeloproliferative neoplasm characterized by high platelet count and increased incidence of thrombotic and hemorrhagic manifestations. It is very interesting, and this was a work by Jan Michels, that increase in the platelet count increases the risk of thrombosis up to about 1 million platelets per cubic milliliter. Then the risk decreases. But at this point, the hemorrhagic risk increases. And the reason for the increase in the hemorrhagic risk is related mostly to a decrease in the activity of von Willebrand factor, due to the fact that platelets produce proteases that cleave high molecular weight von Willebrand factor, and the more platelets you have, the less is the activity of von Willebrand factor. So the bleeding tendency is certainly due to acquired von Willebrand disease, but there are some questions about also platelet function. There are some reports in the literature showing that platelet function in patients with essential thrombocythemia is decreased. And this is probably the largest study on 55 patients with ET, which shows that clearly there is a decrease in platelet aggregation induced by collagen and epinephrine. But I'll come back to this because there are some technical issues that might be very important here. As far as thrombosis, the risk of thrombosis is increased through two main pathways. One is a physical problem due to the fact that all the platelets, but also white blood cells and red blood cells in other myeloproliferative neoplasm increase. There may be an increase in in blood viscosity. In addition, the activation of these cells might bring to stimulation of blood coagulation with the increase of thrombosis. And the typical thrombotic manifestation is arterial thrombosis, venous thrombosis, especially in unusual sites, splanchnic vein thrombosis is typical of this neoplasm. And also thrombosis in the microcirculation. And typical of this thrombosis in microcirculation is erythromelalgia, which is a very painful disease caused by microthrombosis followed by vasodilation, which is very, very painful. And this is very well controlled by aspirin. Actually, aspirin is given to this patient mostly to control erythromelalgia, but it is also given at high-risk patients to control the risk of arterial thrombosis. This is done mainly in analogy with what is being done with patient with polycythemia vera, which is another myeloproliferative disorder, in which it has been shown by my colleague in Rome, Landolfi that aspirin nicely prevents the incidence of arterial thrombosis. We were talking about aspirin in primary prevention this morning, and I said that I don't believe in aspirin for primary prevention based also on the study that we know. This is the only study that I know in which aspirin is highly effective in primary prevention. So these are the patients who might benefit from primary prophylaxis with aspirin. But we know, based on the study by the group of Patrono, that the ET patient may have suboptimal response to aspirin, possibly due to increased platelet turnover. And we'll come back to this later. Now, so the first study that we did was addressing the question whether or not platelet aggregation in essential thrombocythemia is deficient or not. So as I said before, this is the most important study in which it was shown that platelet aggregation induced by collagen and epinephrine was reduced. The problem is that platelet aggregation was studied by lateral emission aggregometry under the following experimental conditions. And here I touch a point that Lina just touched about how you treat platelets in vitro with what anticoagulant. So blood was anticoagulated with sodium citrate, which decreases the concentration of ionized calcium, and this could be important for platelet function. Platelet-rich plasma was used, that is to say, in absence of other blood cells. And PRP had been diluted to a platelet count of 250 per 10 to the 9th liter with autologous platelet poor plasma. And this should not be done anymore, because we have shown that PPP, platelet poor plasma, inhibits platelet function. And it is conceivable that if you want to reach a low platelet count, 250,000 per microliter, you have to add more PPP, more plasma, to the PRP or thrombocytopenic patient because their platelet count is very high. So the more PPP you add, the more you inhibit platelets, okay? So, and it is for this reason that the recommendation of ISTH for platelet aggregation studies is that the platelet count of PRP should not be normalized to a standardized platelet count with autologous platelet poor plasma. So we studied platelet function of ET patients under different experimental conditions. And I had to say that all the patients that we studied were on aspirin because they were on primary prophylaxis. So the data that I show is referring to platelet aggregation independent of thromboxane production because thromboxane production was inhibited by aspirin. And it has been nicely shown that thromboxane production may be even increased in these patients. But so we got rid of this variable, the confounding variable. So we studied 41 patients on chronic aspirin treatment and 29 healthy control who had been treated with aspirin, enteric-coated aspirin for 5 consecutive days. Enteric-coated aspirin is the aspirin formulation which is normally used to prevent thrombosis in this patient, but also for preventing thrombosis in patients with atherosclerotic disease. Now, so we had 5 samples that we studied. One is citrated PRP diluted with autologous platelet poor plasma to 250,000 per cubic millimeter. Citrate undiluted PRP, hirudin undiluted PRP in lateral emission aggregometry. Hirudin does not chelate calcium. And we also use the impedance aggregometry using hirudin undiluted PRP and hirudin whole blood. So we tried to get rid of all the variables that might affect the results of platelet aggregation. 11 of the ET patients had a poor response to aspirin. This is the topic of the final part of my presentation. So we did not include the results of platelet aggregation studies of these 11 patients because they might affect the global results. So very simply, I present you some of the many data that we developed. Indeed, we confirmed that when we studied collagen-induced platelet aggregation in citrated PRP diluted to a standardized count, ET patients had a much lower platelet aggregation compared to controls. However, when we studied citrate undiluted PRP or hirudin undiluted PRP, there was absolutely no difference between ET patients and controls. And this is due to the inhibitory effect of autologous PPP to dilute PRP. And as expected, the inhibitory effect of diluted PRP was more evident in ET patients because we need to add more platelet poor plasma in their samples compared to controls. When we studied platelet aggregation in whole blood with the multiplate in Hirudin, we found exactly the opposite. The aggregation was higher in ET patients compared to controls. And this could be due to the fact that the platelet count can affect the results of platelet aggregation studied by impedance aggregometry. So results of in vitro platelet aggregation in ET patients are greatly affected by the method used compared to healthy control. Platelet aggregation of ET patient was impaired in citrated and diluted PRP, normal in undiluted PRP, increased in Hirudin whole blood. And so abnormalities of platelet function unlikely contribute to the bleeding risk of ET patients based on the results, I believe. Now, the second part of my presentation is related to the response to aspirin in essential thrombocythemia. I showed you that Pascale and co-workers showed that ET patients may have suboptimal response to the drug, possibly due to increased platelet turnover. And they reached this conclusion based on this finding. They saw that many patients had high serum thromboxane B2, which means that the platelets were not well inhibited by aspirin. And this was correlated with the number of reticulated platelets, or platelets that are newly formed and enter the circulation. So they suggested that patients should be treated not with once daily aspirin, but with twice daily aspirin in order to prevent this effect. And as a matter of fact, with twice daily aspirin, the amount of serum thromboxane B2 is reduced, but again, there are some patients whose serum thromboxane levels is very high. This suggested that there may be some additional mechanism which may account for the resistance to aspirin in ET patients. So we explore three hypotheses. First of all, that there may be a defective pharmacodynamic effect of aspirin on platelets. So we studied the effect of aspirin in vitro on thromboxane B2 synthesis. And we saw that the EC value for inhibition of thromboxane synthesis in normal subjects and not taking aspirin, of course, and patients with resistance to aspirin was similar, which means that there is no pharmacodynamic defect in these patients. The second hypothesis is that maybe patients with ET had increased hydrolysis by esterases. Acetylsilic acid is rapidly esterased to hydrolyzed to salicylic acid. So we wonder whether the activity of these esterases is higher in ET patients compared to controls, which might account for a reduced pharmacological effect of aspirin. But again, you can see that there was absolutely no difference between ET patients with poor response to aspirin, ET patients with normal response to aspirin, and controls. So also the second hypothesis was not true. The last hypothesis is that there could be an impaired intestinal absorption of aspirin. And indeed, we did find that although control subjects and patients who are responded to aspirin had a good absorption of aspirin, you can see that AUC is similar in the two groups. Patients with poor response to aspirin had a much lower concentration of aspirin in their plasma. And also for the same was true also for salicylic acid, which is the byproduct of aspirin. And these are reflected in a much higher level of serum thromboxane B2, not only at 24 hours, as Pascale showed, but also after, up to 8 hours after they witnessed intake of aspirin by these patients. So, yes, indeed, impaired absorption of aspirin could account for the resistance to aspirin in patients with thrombocythemia. But the important part of this is that these patients had been treated with enteric-coated aspirin. What happens if they are treated with plain aspirin? There are differences between enteric-coated aspirin and aspirin. The absorption is in the small bowel for enteric-coated aspirin and in the stomach for plain aspirin. And the Tmax is much delayed for enteric-coated aspirin compared to aspirin. So we wonder whether the difference that we saw might be also related to the formulation of aspirin used. As a matter of fact, when we studied again all the patients with the plain aspirin, we absolutely found no difference in terms of absorption of aspirin, both in control ET patients who are resistant or who are poor responders to aspirin, compared to enteric-coated aspirin. You can see there is absolutely no difference here and a great difference here. And also in terms of serum thromboxane B2, you can see that plain aspirin can inhibit very well, and similarly to normal subjects in all the patients with essential thrombocythemia. But at 24 hours, there was indeed a higher level of serum thromboxane B2 in ET patients independently of their response to aspirin. And this could indeed be due to the fact that there are more reticulated platelets 24 hours after the intake of aspirin in ET patients. And as a matter of fact, we could reproduce the same result that Pascal et al. Showed about the correlation between serum thromboxane B2 and reticulated platelets. We do not think that this is due to increased turnover, because there is no reason why these patients should have an increased turnover of platelets. It is due to increased production of platelets, in our opinion, but I don't have the time to show this to you. And for, again, if we give aspirin every 12 hours instead of 24 hours, we can get a much better inhibition of thromboxane production in all patients, also at 24 hours. So, in conclusion, the poor pharmacological response to enteric-coated aspirin in ET patients is associated with the reduced intestinal absorption of the drug, which was not observed when plain aspirin was administered, increased platelet production, not turnover, and the consequent increase in the reticulated platelets in ET patients is associated with the high serum TXB2 levels 24 hours after the administration of the drug, both in responder and non-responder, and the administration of plain aspirin every 12 hours instead of 24 hours keeps serum thromboxane B2 levels low until the next dose of the drug. Now, this is just the last slide. Why are we using enteric-coated aspirin instead of plain aspirin to prevent thrombosis in our patients? This relates also for not only to ET patients, in general for patients who are at risk of myocardial infarction. But this was due because it was thought that enteric-coated aspirin could induce less gastric complication, less GI bleeding compared to plain aspirin. But as a matter of fact, studies, well-performed studies showed that there is absolutely no difference. Oh, shoot. There is absolutely no difference in terms of GI bleeding with plain aspirin and enteric-coated aspirin. And for this, I thank you for your attention. These are my collaborators who helped me in this. Thank you.
Thank you very much, Professor Cattaneo, for the excellent and interesting lecture. Have a question? Any? Do you have a question? No. Oh. So what about the chewing the aspirin? And would you suggest twice daily uptake of aspirin in every situation, or only in thrombocytopenia?
No, only in a patient with a thrombocythemia who had very, very high platelet count. Only for those.
Okay, thank you very much. Professor
Telepis?
Diabetic patients have also a high turnover of platelets. So 2 times per day aspirin maybe also.
Well, if you read the work by Carlo Patrono, which you're referring to, they also compare patients with coronary artery disease with diabetes and without diabetes. And the increase in serum thromboxane B2 with time at 24 hours was very similar in diabetes and non-diabetes. I don't know for what reason it is believed that the problem relates only to diabetic patients, related with any kind of platelet. There is no increased turnover in diabetes. So if we think that giving aspirin twice daily is okay, we should use it for every patient. Indeed, also for patients who have normal platelet turnover, 24 hours after the last intake of aspirin, 10% of platelets, circulating platelets, have not been inhibited by aspirin. So if we want to reach a better degree of inhibition of thromboxane production, maybe 5% at highest, we should give aspirin twice daily and not once daily. Not only for diabetic patients, but the issue is well, are we sure that 5% is better than 10%? We don't know that. Thank you.
Yeah, well, thank you. Although this is not so sure because we can have bleeding gastrointestinal, we can have gastrointestinal to tell that we have to do that generally. To give
No, I didn't say that.
Ah, okay.
No.
Because there's, okay.
I said that if we want to. If we are sure, if we want that to decrease the number, well, serum thromboxane B2 before the next administration of aspirin, and we want to decrease it by half, giving it twice daily, we should not do it only for diabetic patients, but we should do it for everybody. But first of all, we should make sure that this is clinically effective and safe.
Exactly.
I'm not doing it to anybody, okay?
Thank you very much. That's good. So now the next and last presentation of this